Thursday, April 23rd. For those of you who are not sure what day it is, I have this on my calendar. So my name is Molly MacDonald. I'm founder and CEO of the Pink Fund. I have the privilege of working with an awesome team to provide limited but critical financial assistance to women and men in breast cancer treatment who have experienced a loss of income. And more recently with the COVID-19 challenges, those numbers are increasing. Tonight, I want to introduce you to integrative oncologist, Dr. Sheba Roy, who works here in Michigan. And she's going to share a lot about her practice and what she does. I met Sheba, we think it was around 2014 when she came to Michigan from, I want to say Philadelphia. Is that correct?
It is.
Yeah, from Philadelphia. And we met, we were filming a segment for another physician here who has a show called Ask Dr. Nandi. And also I have been a patient of Dr. Roy's and benefited from her wonderful care. So Dr. Roy, I'm handing this over to you. Introduce yourself and open up, and then we'll ask a few questions.
I just want to thank the Pink Fund for the work that they do. And I want to thank Molly. I've known her to be such an advocate and a pioneer for breast cancer patients who do need that financial assistance. And I've been really thrilled to see the organization grow. As Molly said, my name is Dr. Roy, R-O-Y, and you can find us on our website, which is AIM, as in Associates of Integrative Medicine, natural.org, aimnatural.org. She said that I was an integrative oncologist, and I think that's a difficult term to understand. So I just want to take just a second, Molly, and explain what that means. In Michigan, the term integrative, holistic, natural doesn't really mean anything. Anybody can call themselves those things. Those aren't licensed terms. What I am is a board certified doctor on the interactions between natural therapies and nutrition, chemotherapy, radiation, and surgery in a cancer population. In other words, when someone is diagnosed with cancer, my job is to, one, prevent and treat the side effects from chemotherapy and radiation, optimize surgical outcomes, and two, to help them to choose therapies in the complementary world that are going to be supportive of their treatment and not compete with their conventional treatment. So typically our patients come directly from oncology. We work with all the hospital systems, but in particular, Beaumont, Henry Ford, U of M send a lot of patients to us, but we do work with St. Joe's and Carmanos as well.
So Dr. Roy, this is such great information because patients are looking for ways to reduce side effects, boost their nutrition. We're here in Michigan, but the Pink Fund is a national charity. How would people find a similar physician or practice to AIM outside of Michigan?
That's a really, really good question. So first of all, there's only 75 of us in the United States and Canada. So it can be hard to find someone like myself. In Michigan, there are actually 4 of us, one of us in training. Dr. Shruti March also works in my practice. And as far as I know, she's the only fellow of the American Board of Naturopathic Oncology who's also working solely in nutrition and oncology. But if you go on a website called oncanp.org, so that's ONC as in oncology, ANP as an American naturopathic physician, oncanp.org, and you click on your state and click on find a doctor, you can find someone like myself. Unfortunately, a lot of doctors can register with that directory, and so you're looking for someone with the letters FABNO after their name. So Fellow of the American Board of Naturopathic Oncology, FABNO. A person who's a FABNO has done a 6-year doctorate in conventional plus evidence-based complementary alternative medicine. In addition, has done residency and fellowship. So fellowship is either 2 years in a hospital-based oncology program or 5 years is an affiliate in a hospital-based oncology program and sits for national boards. So it's a very traditional tract, and there's only 6 fellowships in the country nationwide.
So let's talk about when a patient is diagnosed with cancer. We'll use breast. Pink Fund is a breast cancer organization. And it's a patient who's going to undergo mastectomy, chemotherapy, radiation, and aromatase inhibitors for 5 to 10 years. So they've kind of got the full soup to nuts treatment, so to speak.
Mm-hmm. Mm-hmm.
They come to you, and what can they expect in the first appointment?
So it's these are excellent questions, because I think we're just walking people through all the steps. So first of all, when they come to me, it's better the earlier we are in that treatment trajectory, the better, because it's always best to prevent rather than treat side effects. When we're later in the treatment, let's say we finished that course of treatment and we're getting endocrine therapy or hormonal blockers, then in that part of the treatment, we're doing risk of recurrence, so lowering the risk of recurrence and survivorship. Mm-hmm. But let's start in the beginning. So let's say someone's just diagnosed. They would come in and see us for an hour, hour and a half, and we would go over all of their records with them, map out their history, and draw out an algorithm for how did this happen. So the big question for a lot of people is, how did this happen? What in my body, what makes my body hospitable to cancer? What are the outside factors that are contributing to disease? What are the drivers? So we know that inflammation is a driver for cancer growth. We know that how we use fat and sugar is a driver for cancer growth. And we also know that genetics, family history, environmental exposures, all of those things contribute. So it's really important in that first session to identify how does that person show up in the world and how is breast cancer individual to them? Because while it is in some senses an epidemic, at some point in our lives, all of us will either know someone or be diagnosed with some sort of cancer. It does show up individually for each person, and it doesn't behave the same in each person, despite, as you said, our soup to nuts treatment that's pretty standardized. So we would then do blood work. So we would work with their oncology team. So all of their treatment goes through oncology. And we would do a comprehensive panel where we're looking at not just their liver, lungs, and kidneys and their immune system, but also their nutrient factors, how their body uses fat and sugar. Where is inflammation in the body and how is it showing up? What kinds of other predictive factors can we look at? For example, let's say someone is getting adriamycin, which, as you know, is a very common drug to start out with breast treatment. The question is, do they have any pre-existing factors that would predispose them to heart disease? And how can we offset that and protect their heart long term? Side effects from drug treatment can last for anywhere from 5 to 15 years. So it's really important that we start out with good baselines. Go ahead.
Side effects from the adriamycin, the chemotherapy, can last 5 to 15 years.
Mm-hmm. They can show up 5 to 15 years later. So we have what are called acute or immediate side effects, and then we have side effects that show up later in life. So it's really a lifelong.
So I'm sorry. Later, sorry to interrupt. The ones that show up later, what types of side effects would those be?
Sure. So it depends on the drug, right? So let's say we're talking about adriamycin in particular. In that case, or doxorubicin is another name for that drug. In that case, what we're looking at is heart disease long-term, but also impacts on the kidneys long-term. Okay. And sometimes people who are on adriamycin are also getting a drug called Herceptin. Let's say they have a HER2 positive cancer and not just an estrogen progesterone positive cancer. In that case, they're going to have a compound risk for heart disease. Let's say that person comes to treatment with a little bit of weight on them. Let's say they have a previous history of heart disease. Let's say that we're African American or Arab American. In that case, we have increased risk of heart disease later on. Let's say that we start out with hypertension. all of those things need to be individualized to that person, and predictive values can be drawn. So I can actually map out with that individual in the first session, what is this picture going to look like with care, and what is it going to look like without care? And my goal and my job is to make sure my patients not only never recur, but also that they don't get heart disease, diabetes, that their weight is well managed, and that they're able to live long and healthy lives, not as a cancer patient, but rather as Molly MacDonald or Sheba Roy or whomever the patient is. Does that make sense?
Yes. So I know that I was speaking at a Coleman metastatic conference in St. Louis in late February, and we asked about some integrative medicine to manage side effects. And one of the comments of the metastatic patients was they found that some of these things worked, but insurance didn't cover it. So can we talk a little bit about average costs for some of these things? And what a patient might be able to do. Because I always think, to me, I'm thinking, well, it's worth it. I mean, this is your life. This is your quality of life. If your quality of life is better and acupuncture and certain supplements and things are improving that, massage, whatever that might be, I would think that you would give up something else in order to achieve better health. But I'd like to talk about insurance coverage or not, costs of care.
So I want to go back to a couple of things that you said. One, you said that you used the word metastatic. So I just want to make sure. I know a lot of our population already knows what that means, but what it does mean is that in this person, breast cancer has showed up somewhere else in the body, so they may always be in treatment. Those patients still not only benefit from an integrative model, but excel in an integrative model. So half our patients actually come to us stage 4, meaning the cancer has moved to somewhere else in their body. And I have patients that are 17 years out, stage 4 with breast, doing very well. And I have patients who are 7 to 8 years out, doing very well. It's very rare that patients don't do well. So the next point that you made is people see benefit. When we talk about giving natural therapies, to cancer patients, we're not talking about sort of what's available on the internet. We're talking about therapies that have been shown in clinical trial to be effective when partnered in or in survivorship to lower risk of recurrence and lower side effects. We don't actually recommend natural therapies that don't have evidence yet. While we might support the patient in using them, it's really important that we use the same guidelines that oncology uses in terms of administering care. So all of this is evidence-based, and all of it should be standard of care in this country. Now, that leads into the question about insurance. Why is it not? In the state of Michigan, your insurance does not cover the cost of natural therapies. However, there are 27 states that do. It's just that Michigan is behind. And one of the reasons it's behind is it has a strong pharmaceutical lobby. And another reason it's behind is because it's a conservative medical community. Oncology is a conservative field. And there's a big push by family physicians, actually, to push back against natural medicine because it's somewhat competitive. If we can treat a common cold or a UTI using some natural remedies versus antibiotics or steroid treatment, then most patients will push for that. So it really requires you talking to your representative. There's a bill on the table in Michigan now to cover natural therapies under your insurance, and it's passed through the House, I believe. But I will send that to you. You can upload it in a link, Molly, and people can just write to their representatives. So yes, it is expensive, therefore, to see someone like myself. It's an out-of-pocket cost to you. But that cost, as you said, has to be weighed against the cost not just of your quality of life, but your life itself. It's not astronomical. So when a family physician builds insurance for an hour's worth of care with you, the reimbursement would be anywhere between $1,500 and $3,000. It's just that the patient isn't seeing the cost of medicine. And there's nothing more expensive than being ill or being sick. Nothing more expensive. Emotionally, psychologically, our marriages suffer, our families suffer, we suffer. when we are sick. So our goal is to keep you out of our office, not in our office. Patients only see us for 2 to 3 times a year when they're well. And we do financial counseling in the beginning to kind of map out what that's going to look like for a year and come up with a prediction around a budget. It's a capped cost, so we don't just keep seeing the patient eternally. We think about together as a partner, us and the patient, what their finances look like, and for every single person, that's individual. We do make sure that we're not exclusive. So we see patients no matter where they are in their financial lives, and we make it work. And that's really an individual conversation. It's not something I want to talk about on a Facebook Live.
Right. So you don't have a price menu like at the restaurant,
We do have, go ahead.
Well, it sounds to me like you are tailoring your program for each patient for the best outcome based on their personal financial situation and ability to pay.
Yes, but I don't want people to think that there isn't a standard rate per hour. What I mean by that is, let's say someone needs more care than less, then we might minimize the time of visit to 15 minutes every 6 weeks or 8 weeks versus these 2 long 1-hour visits. We might avail ourselves of other resources that they could use to supplement what they're doing with me. We might break up that visit over a period of years or a period of year, or break up that cost, So we find ways to work with their insurance. Insurance will cover everything I do. They just don't cover the time to talk. So again, it's not astronomical, it's just the time to talk. Mm-hmm. If we're only using 2 hours a year, we cover through insurance all the blood work, procedures, referrals, nutrition, stress management. So all of the other pieces are less burdensome. And patients usually find that it's manageable. I see a question on the chat about telemedicine. Right now, during this COVID crisis, we're seeing everybody by telemedicine, unless they're patients who have high-level needs, in which case we need to see them at home or in clinic.
This is such amazing information, Dr. Roy. I'm really blown away and impressed how thoroughly everything is thought out. So, is there any type of cancer that you do not treat?
There is not. That's also a good question, but I've been in practice for some time. I would say I'm very good at what I do. And we have 2,000 patients, and I've seen probably 10,000 now over my career, and I don't know that there's a cancer I haven't seen yet. I would say a very large percentage of our population is breast, and a very large percentage of our population is actually ovarian. We see a lot of prostate, we see a lot of colorectal, which kind of falls along the lines of what we see demographically in the country. And we see a percentage of lung and pancreatic. And then, in between, there's the rarer cancers like neuroendocrine, but we see everybody. Because after we map out that first, really it's a whiteboard. We use a whiteboard, we kind of map out for you, what does it look like to be you? How did we get here? What is the future going to look like? And what are we going to do to serve you? And then after we get the blood work back and we go over the blood work step by step, this is what's going on in your body, and we design treatment. We design treatment for each treatment change. So you mentioned, for example, someone who has gotten chemotherapy and radiation and now is in hormonal treatment. Hormonal treatment, as you mentioned, is 5 to 10 years. Depending on whether you're on tamoxifen or on aromatase inhibitors, you may have changes in your hair, skin, and nails, changes with vaginal health, changes with your bone health, changes with your heart health, mood issues, changes with hot flashes and how you manage stress. But most importantly, what a lot of patients don't know is you will see changes in how your body uses sugar and fat. So you'll see a rise in your lipids and a rise in your sugar, and you'll see some abdominal weight start to build on. So what the next piece that we do is partner you with nutrition and counseling to bring that weight down and lower your risk of recurrence long-term by controlling lipids and sugar. So each step of the way, all of this changes based on what the patient looks like and where they are in treatment.
So
and if we're
go ahead.
If we're talking about other cancers, that's going to be very different, right? Someone with a neuroendocrine, we're looking at cure or survivorship. We're not looking at a breast care patient who should not look at cancer as a death knell, but rather look at cancer as an opportunity to reframe how they're thinking about their life journey and their relationship to their health, because it is a long-term process.
So I have two questions. What about pediatric cancer?
Mm-hmm.
Do you treat children?
So we do see peds. It's very hard, but we do.
Mm-hmm. And then my other question is, here we are in this high stress time. I was talking to a friend the other day, and he said, at the end of this thing, I'm going to have to go to AA and Weight Watchers. And so, we know that so much of inflammation is around diet. Give us some recommendations on other alternative ways to manage stress during COVID-19 with respect to our diet.
With respect to your diet. Okay. One comment you just made about AA and Weight Watchers, you can attend 12-step meetings online by Zoom right now, and you can do so also anonymously. If you just log on to just Google their websites, you're able to log on to those meetings every day, multiple times a day. And that includes OA, which is not Weight Watchers, and it has a terrible title. It's Overeaters Anonymous, but it's an excellent meeting. The people in it are really not necessarily overeating. It's just people who eat compulsively. Mm-hmm. When we're eating for stress, like stress eating, is a huge piece of what's happening right now. And those meetings are very helpful to help you to come up with coping mechanisms and to start to reframe your relationship with food. So I think...
I was going to say, and the wonderful thing about both of those organizations is they're free.
They're all free, yes. So I want to say about stress and your diet and COVID. First of all, I'm not the best person to talk about food. Shruti March, who works in my practice, specializes in nutrition and oncology. She's in her third year of fellowship, and she has developed a program actually for postmenopausal breast cancer patients who are having a hard time losing weight. And that program has been 100% successful across the board. Every single person in it has lost weight. But the way that they've lost weight is by reframing their relationship with food. I think what's unusual about this crisis right now, Molly, is that it's forcing us to really look at how we cope. Because we're locked in, right? It's putting a lot of pressure on our marriages. It's putting a lot of pressure on our relationships with our children. It's putting a lot of pressure on our relationships with our coworkers. And we're finding that we default to those stress patterns around, let's say, diet, or let's say how we use food. I think if I would just give a couple of tips, and then I want to go back and talk a little bit about what I mean by stress. But the tips would be, 1, those Overeaters Anonymous meetings are really excellent. 2, planning out your meals and planning out your in particular, your sweets. So if you know that you're going to have sugar cravings, and you know you're going to want something sweet, planning out what that's going to be for the day or for the week, and giving yourself portions and allowing yourself to do that. When you start to feel at the end of the night like you're bored and there's nothing else to do and you want to eat, starting to recognize those feelings, like what's coming up for me? Why am I bored? Or why am I feeling this way? And letting yourself sit with that for a moment and see if there's anything else you can do with that feeling besides feed yourself. When we eat, it triggers a neuroendocrine and hormonal cascade in our brain that looks like pleasure to us. And that's why we're doing it, because it makes us feel good. But if we start to come up with other ways that we can meet those needs to feel good, this could be a time of transformation rather than a time where we just gain the COVID-15, so to speak.
So I years ago read about the bliss factor, which was the combination of salt, sugar, and fat in processed foods that creates this good feeling, right?
Mm-hmm, mm-hmm.
And so we eat more of it, and it keeps getting bigger and bigger and bigger. So we have to find a new way to find bliss that's not sugar, fat, and salt, or at least portion control, I guess.
Yeah, and it's painful. For myself, even being when we moved onto telemed, being quarantined at home, it put a lot of pressure on a very new marriage for me, and that's very painful to recognize that we may not have the coping strategies that we thought we did, the communication strategies that we thought we did, and that there may be parts of myself where I haven't cultivated my joy. When we're used to going to work every day, that becomes our routine, and we're able to almost disassociate from the parts of ourselves that are connected to joy and to what makes our life worth living, right? So I became a really excellent doctor, and I'm really good at being Dr. Roy, but I'm not so good at being Sheba and being a wife or being a mother or being at home. And I think that one of the things that's very painful about this crisis for us is as we face that, what we've tended to do is start to watch a lot of TV or eat a lot or do those things to, again, continue to try and manage that pain.
Mm-hmm.
But if we lean into it and we let ourselves experience it, what I've found, at least for myself, I've started to try and find the things that, as you said, bring me that bliss. I've started biking, for example. Started praying a lot and really relying on scripture. I'm not proselytizing here. It's just my thing.
Mm-hmm.
I've started really looking at food. For me, food has been a way of coping. I've really started looking at that. I find that eating a really high protein breakfast and focusing on one meal that I can really put my energy into stabilizes sugar throughout the day and helps to stabilize those cravings. But really leaning into the pain is where I've started to recognize where myself I may not have been focusing my energy. And then at the end of it all, Molly, are we living the life worth living if we've spent all this time disassociating from what brings us joy? And if we just spend ourselves time feeding it?
So, what I appreciated about you in the last few weeks is some of the email newsletters where you've been very transparent about the challenges this has brought to you, not only as a physician, but you said as a wife, a mother, a friend. How can people sign up for your newsletter so that they can benefit from all this great advice you're giving?
Mm-hmm. So you can just go on the website. Again, it's AIM, Associates of Integrative Medicine, Natural, so AIMnatural.org, and click on Contact Us, or there's actually a sign-up box for the newsletter there. We try to post a lot, so we post at least once or twice a week, and it's not just on what's going on with us, but really solid advice on how to stay well during this time and how to lower your risk of recurrence when you can't get into oncology. So we have a lot of patients whose treatment is being delayed right now, or whose treatment has changed from standard of care because of the crisis. And that's been catastrophic for some and difficult to manage. So it's really important that you learn how to take care of yourself during this crisis. And we post a lot on nutrition as well. So recipes, nutrition strategies. Dr. March did a talk with Gilda's and Lake House a couple nights ago on how to manage food during this crisis. So, and that's also I think that's posted nationwide as well. So those talks are also there.
So this has been great. Our time is up. I'd love to have you back. I'm sure we're going to get great feedback on this. Thank you so much for your time, for your transparency, for your passion for the work that you do. And again, if you want to get a hold of Dr. Roy, it's aimnatural.org. Mm-hmm. And we will be putting up everything that she has shared with us on our website, and you can access a downloadable document that way.
Yeah, and I want to say thank you, Molly. I just think that the Pink Fund, like I said, I met Molly earlier when it was just a statewide organization. Yeah. And in the interim, she's really done extraordinary things to serve this population. So it's an honor to work with you, and it's an honor to speak with you.
Thank you so much. Enjoy your evening and eat a healthy dinner.
Yes, let's all stay well and stay safe.